Nasimul Islam, welcome you all to today's webinar on prostate cancer pathology. This program is jointly organized by Bangladesh Academy of Pathology and Department of Pathology, Bangabandhu Sheikh Mujib Medical University. Dear participants and members, I hope you all are well, particularly in this COVID situation. I know many of us are passing difficult times. Many of our respected colleagues are compelled to curtail or refrain from everyday practice. Despite these various limitations, we are keen to pursue our goal of achieving knowledge and acquiring skills and continue our academic activities. May Allah help us stay safe and remain healthy. Today, we have several distinguished members of our community as panel of experts. Professor Syed Mukarram Ali, sir, is Chairman, Delta Medical Center. Professor Muhammad Kamal, ex-Chairman and Professor of Pathology, Department of Pathology, Bangabandhu Sheikh Mujib Medical University. Professor Kamrul Hassan Khan, ex-VC and Professor of Pathology, BSMMU. Brigadier General Sheikh Mohammad Jainul Islam is head of the Department History and Cytopathology, Army Pathology, FIP. আমাদের সঙ্গে আরো আছেন ডক্টর মোহাম্মদ ফজল নাসের, is Associate Professor of Urology, Shahid Surardi Medical College, and lastly, Dr. Saika Habib, Associate Professor, Department of Pathology, BSMMU. Dear participants and members, please mute yourself during the session. Please submit your question in the chat box during presentation. Our panel of experts will give their comments. Each will have 2 minutes. Before starting the presentation, I request Professor Ashim Ranjan Borua, sir ki এসে গেছেন? আচ্ছা, স্যার যদি না আসেন তাহলে আমি শুরু করতে চাই।
অসীম স্যার আসছেন?
অসীম স্যার আসছেন? স্যার তো এসে, স্যার আপনি কিছু বলে দেন স্যার আমাদের। Please welcome address from Professor Ashim Ranjan Borua. He is the President of Bangladesh Academy of Pathology. Please welcome Professor Ashim Ranjan Borua.
আচ্ছা, শোনা যাচ্ছে আমাকে? শোনা যাচ্ছে?
হ্যাঁ স্যার শোনা যাচ্ছে।
ধন্যবাদ। শুভ সন্ধ্যা। আমাদের এখানে উপস্থিত আছেন আমাদের অত্যন্ত শ্রদ্ধেয় স্যার মুকাররম আলী স্যার, আমাদের কামাল, প্রফেসর কামাল সহ আরো আমাদের প্যানেলিস্ট যারা যারা আছেন। কানে আপনাকেও দেখতে পাচ্ছি, আর অনেকে সবার চেহারা পরিষ্কার বুঝতে পারছি না যদিও। যাই হোক, আমি সবাইকে আবার শুভ সন্ধ্যা জানাচ্ছি। এবং আজকে যে একটা সিএমই হতে যাচ্ছে, এটা আমাদের করতে যাচ্ছে আমাদের প্রফেসর গোলাম মুস্তফা। এটা আমাদের আরো আগেই হওয়ার কথা ছিল, কিন্তু করোনার জন্য আমাদের এটা জিনিসটা একটু অন্যরকম হয়ে গেছে সবকিছুই। গত মার্চের খুব সম্ভবত ফেব্রুয়ারিতে আমরা একটা মিটিং করেছিলাম বিএপির, তারপর থেকে আমরা আর কোনো মিটিং বা আর কোনো কিছুই আমরা করতে পারিনি। তবে যাই হোক, আমি ধন্যবাদ জানাচ্ছি আবার আমাদের সায়েন্টিফিক যে সেক্রেটারি, তাকে ধন্যবাদ জানাচ্ছি যে আজকের এই সিএমই অনুষ্ঠানটা আয়োজন করার জন্য, এবং এখানে আমাদের স্যাররা জয়েন করেছেন, এই জন্য আমি খুব আনন্দিত বোধ করছি। এবং আমি আশা করি আমাদের আজকের এই প্রোগ্রামের মাধ্যমে এটা শুরু মনে করি আমি। এবং এই করোনা কতদিন চলবে আমরা জানি না, কবে আমরা মিটিং করতে পারবো ঠিক মতো সেটাও জানি না। সুতরাং এর মারফতে আমরা এই জুম মিটিং এর মাধ্যমে যদি আমরা শিক্ষণীয় এই জিনিসগুলো আমরা চালাতে পারি, তাহলে হয়তো আমাদের জন্য ভালো হতে পারে। অনেকে অনেক আগে থেকেই করছে, কিন্তু আমরা করতে পারিনি, এটা আমাদের ব্যর্থতা। যাক, ব্যর্থতা নিয়ে বসে থাকলে চলবে না, আমরা সামনে যাতে আরো এটি করতে পারি সেই বিষয়ে আমি সবার দৃষ্টি আকর্ষণ করব। বিশেষ করে সায়েন্টিফিক সেক্রেটারি যিনি আছেন, আমি আপনার দৃষ্টি আকর্ষণ করবো যাতে আমরা আরো সুন্দরভাবে এগুলো করতে পারি। দেখ, আমি এর কথা বাড়াবো না, আমি সবাইকে ধন্যবাদ দিয়ে আমার আজকে এই অনুষ্ঠান শুরু করার জন্য আমি অনুরোধ জানাচ্ছি। ধন্যবাদ সবাইকে।
Thank you, sir, for your inspirational speech. Now it's time for main event. Professor Ghulam Mustafa does not need any introduction. He is a renowned histopathologist of our country with vast experience in the field of pathology. Today, he is going to share his experience with us. The title of his topic is Prostate Cancer Pathology. Respected audience, please welcome Professor Ghulam Mustafa.
শোনা যাচ্ছে কি?
Yes, you are audible.
হ্যাঁ শোনা যায়।
Please.
দেখা যায়? আমার স্ক্রিন দেখা যায়?
হ্যাঁ দেখা
জি
যাচ্ছে।
দেখা যাচ্ছে।
আচ্ছা। Respected chairman of BAP, member of the panel of experts, my senior and junior colleagues, good evening. Today, my presentation is on prostate pathology. Actually, I have decided it into two parts. One is basic, which is mostly dedicated to the junior, to the residents, and there will be another part that will be advanced. Now, আমি একটা chat box একটা link পাঠিয়েছি। এক সেকেন্ড।
হ্যাঁ পেয়েছি সেটা।
এটা বলো। একটা লিংক পাঠিয়েছি এই চ্যাট বক্সে। তো ওই লিংকে ঢুকতে হবে, সেটা আমি বলবো কিছুক্ষণ পরেই। সেখানে আমরা প্রথমে একটা ছোট্ট এক্সারসাইজ করব, তারপরে আমরা মেন টপিকে যাব। So our topic is prostate pathology. আমরা প্রথমে দেখব যে আমরা কোথায় আছি। আপনারা এখন হলো ওই লিংকে ঢুকে এই যে একটা ইমেজ আছে, এই ইমেজের কতগুলি আনসার দেওয়া আছে, জাস্ট লাইক মাল্টিপল চয়েস কোশ্চেন, এবং সেখানে আপনারা প্রত্যেকে ঢুকে আপনাদের ওপিনিয়ন দেন। এরকম 5টা
দুইটা লিংক
ইমেজ আছে,
দেখা যাচ্ছে।
সেই 5টা ইমেজের পরে আমরা শুরু করব।
প্রথম
এটা
লিংকটা
অনেকটা প্রি টেস্টের মতো। লিংকে কি ঢোকা যাচ্ছে?
হ্যাঁ রাইট।
লিংকে ঢোকা যাচ্ছে কিনা?
একটু সময় নিচ্ছে। ক্লিক করেছি কিন্তু
লিংক
সময় নিচ্ছে।
বুঝতে পারতেছি না আমরা।
চ্যাট বক্সে এই যে চ্যাট আছে, একটা অপশন চ্যাট, এই চ্যাটে একটা লিংক দেওয়া আছে, ওই লিংকে ক্লিক করতে হবে।
আচ্ছা প্রফেসর গোলাম মুস্তফা, দুইটা লিংক কিন্তু পাচ্ছি এখানে, কেমন? একটা হলো ফ্রম প্রফেসর গোলাম মুস্তফা টু এভরিওয়ান, এটা হবে না?
হ্যাঁ ওইটা এই যে কয়েকজন তো অলরেডি
চ্যাট বক্সের অন্যরা চলে আসছে, তোমার থেকে যেটা এসেছে সেটা।
হ্যাঁ না ঠিক আছে, এই তো বেশ কয়েকজন এটা ইয়ে করছে আর কি।
আচ্ছা দেখি
আচ্ছা আমি নিচে আবার আর কি লিংকটা https অ্যাড করে দিয়েছি যাতে ক্লিক করলে সরাসরি ঢুকে যায়। ওটা অ্যাড করা না থাকলে আবার
আচ্ছা ঠিক আছে
হ্যাঁ
ঠিক আছে। হ্যাঁ এই তো
অলরেডি হ্যাঁ করা শুরু করেছে, ঠিক আছে।
হ্যাঁ করা শুরু করেছে। আমরা একটু তাড়াতাড়ি করে ফেলি প্রত্যেকে। ঠিক আছে, আমরা এটার যে রেসপন্স আমরা পেলাম, মিউসিনাস মেটাপ্লেশিয়া 63%। এটা তো স্ক্রিন আপনারা দেখতে পাচ্ছেন তাই না?
হ্যাঁ
জি
সবাই দেখতে পাচ্ছেন। তো আমরা দেখছি যে 16% আমাদের পার্টিসিপেন্ট ওনারা মনে করছেন এটা নরমাল প্রস্টেট, 3% ওনারা মনে করছেন এটা নোডুলার হাইপারপ্লেশিয়া, 19% মনে করছেন এটা মিউসিনাস অ্যাডেনোকার্সিনোমা প্রস্টেট, 63% মনে করছেন এটা মিউসিনাস মেটাপ্লেশিয়া। কোলোনিক মিউসিনাস অ্যাডেনোকার্সিনোমা এটা কেউ মনে করছেন না। তো ঠিক আছে, আমরা এবার এর পরের কোশ্চেনে যাই। এটা হচ্ছে দ্বিতীয় কোশ্চেন, দ্বিতীয় ইমেজ। এটাও আপনারা এটাও আমরা তাড়াতাড়ি করে ফেলি।
আমার মানে এটা কোন দিকে করতে হ্যাঁ
কেউ যদি দুইবার ক্লিক করে তাহলে কি তার কাউন্ট হবে?
আর দুইবার রেসপন্স হবে না, একবারই
আচ্ছা,
করতে হবে।
রেসপন্সটা আমরা তো করব পাশে যে গ্রাফটা আছে সেখানে, স্যার,
হ্যাঁ
যে
হ্যাঁ হ্যাঁ
বিসিডি
হ্যাঁ
আছে
হ্যাঁ,
সেই গ্রাফের মধ্যে করলে হবে না?
ক্লিক করলেই হবে,
কিন্তু
ওখানে
বোঝা
click
যাচ্ছে না
করলেই
যে
হবে।
আমি করেছি কি করি না, এটা বোঝা যাচ্ছে না।
ক্লিক
এদিকে
করলেই হবে।
আসতেছে তো। আচ্ছা,
আচ্ছা, এইটা তো হয়ে গেছে মনে হয়। তো এখানে দেখা যাচ্ছে কি যে 78% ও এখনো চলছে। 79% পার্টিসিপেন্ট ওনারা মনে করছেন এটা বেসাল সেল হাইপারপ্লেশিয়া, 10% মনে করছেন নোডুলার হাইপারপ্লেশিয়া। ঠিক আছে, এবার আমরা এর পরেরটাতে যাই। এটাও আমরা করে ফেলি। এখানেও ওই একই রকম ভাবে 5টা রেসপন্স দেওয়া আছে।
একটা কলম আছে কলম আছে যা দাদা।
তো ঠিক আছে, এটা মনে হয় হয়ে গেছে। তো এখানে দেখা যাচ্ছে কি 77% আমরা মনে করছি এটা লো গ্রেড পিন, 17% মনে করছেন যে এটা নোডুলার হাইপারপ্লেসিয়া। ঠিক আছে, আমরা এর পরেরটায় যাই। সরি, এইটা আবারও একই রকম 5টা চয়েস আছে। এটাও আমরা তাড়াতাড়ি কমপ্লিট করে ফেলি।
Check.
এটাতে ভয় পাওয়ার কিছু নাই, কারণ হলো কারো নাম টাম কেউ কোথাও উঠবে না। ঠিক আছে, এটা মনে হয় হয়ে গেছে। এখানে দেখা যাচ্ছে 50% মনে করছেন আমরা অ্যাডেনোকার্সিনোমা, 44% মনে করছি অ্যাডেনোসিস। এটাই সম্ভবত লাস্ট, এটাও আমরা করে ফেলি। এখানেও 5টা চয়েস।
Normal prostate. আচ্ছা বুঝতে পারছি।
ঠিক আছে, এটা তো দেখা যাচ্ছে কি যে রেসপন্স, 4টে রেসপন্স এবং মোটামুটি কাছাকাছি। সিটো হাইপারপ্লাস্টিক প্রস্টেটিক অ্যাডেনোকার্সিনোমা 32% আমরা মনে করছি, অ্যাসিনার অ্যাডেনোকার্সিনোমা মনে করছি 26%, বেনাইন হাইপারপ্লেশিয়া মনে করছি 25% এবং 16% আমরা মনে করছি যে নর্মাল প্রস্টেট। ঠিক আছে, এটা হচ্ছে আমাদের একটা ব্রেন স্টর্মিং এক্সারসাইজ এবং এটা আমরা কনসিডার করছি অ্যাজ প্রি টেস্ট। আমরা হয়তো একদম শেষে আবারও একবার এইটা করব, জাস্ট আমরা কি শিখলাম সেটা এর জন্য। আমরা এখন আমাদের মূল প্রেজেন্টেশন শুরু করছি। সো প্রস্টেট is divided into 3 zones: peripheral zone, posterior aspect, and it is palpate with digit. If you insert your finger through rectum, the portion it touches is the peripheral zone, and the peripheral zone is the classic location for cancer. Then the central zone. The central zone is considered resistant to disease. And transition zone, which is the usual location for nodular hyperplasia. Here is a nice picture for showing the zones. So for all practical purpose, our interest is the peripheral zone is the location for cancer, and the transition zone is for nodular hyperplasia. So if you do a biopsy or from the rectum or transrectal, chance of detecting cancer is high. And if we do a transurethral approach, then chance of nodular hyperplasia diagnosis is high. This is a little bit more explanatory. The transrectal biopsy, they put the biopsy gun through rectum to the prostate, and then
সারা দেখতে পায়। আচ্ছা সমস্যা নাই, আসলেও সমস্যা নাই, কিছু হবে না, কিছু হবে না।
আচ্ছা অন্যগুলো মিউট করে দেওয়া যায় না?
Please mute yourself, please.
স্যার আমি প্রথমে মিউট অল করে দিচ্ছি, কল করে দিতে পারি। আপনি স্যার একটু কাইন্ডলি আনমিউট করে আপনি শুরু করেন, তাহলে একবারে সব মিউট হয়ে যাবে।
ঠিক আছে, তাই করেন, তাই করেন। হ্যাঁ, এখন কি শোনা যাচ্ছে?
হ্যাঁ স্যার শোনা যাচ্ছে স্যার।
আমাকে শুনতে পাচ্ছেন কিনা? আচ্ছা ঠিক আছে। সো দিস ইজ দ্য schematic representation, and this is the tissue. You all know we actually deal with these things, and all the other things are dealt by our US colleagues. So our business starts from here. The normal prostate histology. Prostate glands have 2 cell layers, and it is similar to breast. So the second cell layer may be difficult to see, like in breast. The epithelium in glands is folded or tufted, and it is very important. These tufted structure, this tufted.
না, মাইক্রোফোনের সাথে লাগে না, এর সাথে লাগার মতো মাইক্রোফোন নাই। কি বলো, কি না কি?
প্লিজ মিউট করেন।
আমাদের বাসে কে খায় বলো? যাইলেও আবার যা দেওয়া যায় অবশ্য।
সব কথা কিভাবে শোনা যাচ্ছে?
সৌমিত্র,
স্যার নতুন যারা জয়েন করছে তাদের জয়েন করার পরে কয়েক সেকেন্ড সময় লাগে মিউট হতে, তার মধ্যে চলে আসতেছে কথাগুলো।
ঠিক আছে। So this tufted epithelium or folded epithelium, it is very important. And why it is important? It helps to differentiate from Gleason pattern 3. So if we don't find this tufted appearance, then it looks like Gleason pattern 3. Now, the luminal epithelium is often clear cytoplasm. You see like this, the luminal cytoplasm is clear, and nucleus is single. Then corpora amylaceae, these are corpora amylaceae. They are round to avoid eosinophilic bodies with laminations, with these laminations. And they are present in gland lumina, usually in benign glands, but cannot be used to exclude cancer. Even in cancer, you can find this. And it is very common. This should be differentiated from eosinophilic proteinaceous debris, which is associated with cancer. And negative findings, no nucleoli. In normal prostate, you will not find nucleoli. If you see nucleoli, think cancer or high-grade PIN or reactive changes, basal cell hyperplasia. So in normal prostate or in hyperplastic prostate, you will not see nucleoli, no mitosis. These are uncommon even in high-grade prostate cancer. So mitosis is very uncommon in prostate pathology. Here is the normal prostate gland, the basal layer, and columnar epithelium. In inflammatory or atrophy, the epithelium changes from columnar to cuboidal in shape. So, so this one is inflammatory or atrophy, where the epithelium looks like cuboidal, and the epithelium, size of the epithelium and basal cell, size of the basal cell are almost equal. This one is prostatic intraepithelial hyperplasia. Here again, the cell is columnar, but in comparison to this, the nucleus are enlarged and ovoid in shape. Sometimes nucleoli are seen. Sometimes miss in all high grade lesion, you will find nucleolus. And this one is prostate cancer. Here, the epithelial cells proliferate and crosses the basement membrane and they produce glands. So this is the pathogenesis of prostate cancer. Now, immunohistochemistry of normal prostate. Amaker, it marks a epithelial cell, it is negative normally. CK56, CK63, high molecular weight keratin, all are positive because these marks basal cells. PSA positive and prostate specific acid phosphatase is positive. So normally we'll find in this combination. So this CK56 or P63 or high molecular weight keratin is very important because they mark basal cell. And if these are negative, then it indicates that basal cells are not present. Now, what are the specimens we usually deal? So prostate core biopsy, which is done transrectal, then prostate chips, it originates from transurethral resection of prostate, and usually we call it TURP, and it is done for nodular hyperplasia of prostate glands, but sometimes it is done due to obstructing cancer, release of obstructing cancer. Then radical prostatectomy, it includes the seminal vesicle. Radical cystoprostatectomy, it includes the urinary bladder and seminal vesicle. So these are types of specimens we have to deal. Now, approach to prostate sample. So how we will approach the sample? First of all, know the common diagnosis well. So we will have to learn the common diagnosis, and core biopsy is very useful and important in diagnosis of prostate cancer. So scan the slides with 10x objective. It is also very important. Now, common diagnosis, benign atrophy. This atrophy resembles adenocarcinoma, but typically not reported. Adenosis may resemble adenocarcinoma, typically not reported. Prostate adenocarcinoma, which is most important. Then high-grade PIN. It is considered as prostate adenocarcinoma precursor lesion. Another entity, atypical small acinar proliferation. And this atypical small acinar proliferation is used rarely. And when we can use this term, if you have few abnormal appearing glands, but cannot decide between prostatic adenocarcinoma and benign. So when only a few abnormal appearing glands are present, but it is difficult to decide whether it is prostatic adenocarcinoma or a benign lesion, then we can call it atypical small acinar proliferation. Chronic inflammation, acute inflammation, nodular hyperplasia of prostate. So these entities we have to learn, we have to know, so that we can easily differentiate one from another. So first we will discuss about nodular hyperplasia. Nodular hyperplasia, its feature is stromal and or glandular hyperplasia. Sometimes we may find only stromal hyperplasia, but usually we find both these. Now, stromal component. In the stromal component, we have to look for small blood vessels. And these small blood vessels are very important, because if you don't find small blood vessels, then the diagnosis will be smooth muscle tumor of uncertain malignant potential. So smooth muscle tumor of uncertain malignant potential, they lack small vessels. So in both the cases, there are stromal proliferation of a stromal component, but here lack of blood vessels. Now, this entity, this nodular hyperplasia, should not be diagnosed on core biopsy. You can make diagnosis on prostatectomy, you can make diagnosis on TURP samples, but not on core biopsy. And in one series, clinically relevant prostate cancer is seen in about 1.5% of resection for benign prostate hyperplasia. But in our experience, in our situation, this figure is much more higher. Now, differential diagnosis of nodular hyperplasia, urothelial carcinoma. It shows significant nuclear atypia and sometimes prostatic carcinoma, especially the low grade. And the third one is smooth muscle tumor of uncertain malignant potential, as I told before. So this is the nodular hyperplasia. Here, both the components, the stromal components are hyperplastic or hypertrophied, and the glandular component also. Next, acute inflammation of prostate. This may lead to increased PSA, and patient comes with high PSA, and seeing the high PSA, the clinician prompted for a biopsy. So this prostatitis is considered a clinical diagnosis, and cases are usually signed out as acute inflammation. Even some pathologists do not comment on the presence or absence of inflammation. Microscopic findings, neutrophils in the glands, between the epithelial cells or within the stroma. So the key feature is either neutrophil in the glands, between the epithelial cells and in the stroma. Sometimes chronic inflammation or lymphocytes present within the surrounding stroma, and its differential diagnosis is prostatic infarction. So this is the image of acute inflammation, neutrophil, presence of neutrophil within the lumen, the epithelium contains the neutrophil, and even in the stroma, presence of neutrophil. So these are findings of acute inflammation. Next, chronic prostatitis. This is common in comparison to acute inflammation. Chronic prostatitis is common, and it is a non-specific findings. And its etiology is not apparent on histomorphology. Lymphocytes within the glands, between the epithelial cells or within the stroma is the key feature. Only a few lymphocytes are common, especially in the central portion of the gland, and sometimes it is focal. Only one field may be involved. Here is the image. So the lumen contains lymphocytes. The epithelium are also presence of lymphocytes within the epithelium and in the stroma. In the periglandular stroma contains dense infiltration of lymphocytes in this particular picture. So this is chronic prostatitis. Prostatic infarct, our next topic, it is rare, less than 0.1% of core biopsies. And it can mimic cancer, especially urothelial carcinoma. Here, the prostate is usually large, and microscopic feature is classic findings of necrosis, karyolysis, karyorhexis, and pycnosis, all in combination is present. Sometimes squamous metaplasia of prostate epithelium is seen. Corpora amylaceae, if it is present, it helps in calling it benign. And glands maintain normal spacing. And its differential diagnosis is urothelial carcinoma with squamous differentiation. Next, high-grade prostatic intraepithelial neoplasia or high-grade PIN. It is thought to be a precursor lesion of prostatic adenocarcinoma, and its incidence is 5 to 8% on core biopsy. Multifocal high-grade PIN is considered a risk for prostate cancer on rebiopsy. A small focus of high-grade PIN does not appear to be associated with an increased risk for prostate cancer. On rebiopsy, at 1 year, if the initial biopsy had 8 or more cores, low-grade prostatic intraepithelial neoplasia should not be reported. Believed to be irrelevant biologically or clinically. So PIN not otherwise specified refers to high-grade PIN. Low-grade PIN has the architecture of high-grade PIN but lacks nuclear atypia. So this is a high-grade PIN. Here, nuclear enlargement and presence of nucleoli. Microscopic feature of high-grade PIN, medium to large size glands with architectural changes. There are several types of architecture, maybe flat, although flat is uncommon. Then tufting, it is common. Micropapillary, common. Even it may be cribriform in architecture, although cribriform is very rare. And high-grade pin is described as epithelial hyperplasia. And the diagnosis is based on nuclear changes. Hyperchromatic nuclei is the key. It is a low power feature. In low power, you can appreciate hyperchromatic nuclei. And in high power, you can see the nucleoli. So in combination to low power findings and high power findings, you can confidently make a diagnosis of high power, high grade pin. Often increased nuclear cytoplasmic ratio, nuclear enlargement, usually subtle, but at high power magnification, it can be appreciated. Tinctorial changes of cytoplasm, usually amphophilic, even it can be basophilic. Nucleoli should be visible with 20x objective. And if you want to see by 40x, you can overcall. You can make overdiagnosis if you try to see by 40x. And it may need ISC to differentiate from adenocarcinoma. Nucleoli should be present in more than 10% of the cells in a gland to call it high-grade pin. So for high-grade pin, the criteria is strict. In a gland, the nucleoli should be present more than 10% of the cells, although this criteria is not required by all pathologists. And the differential diagnosis, basal cell hyperplasia of the prostate, intraductal carcinoma of the prostate, even prostatic adenocarcinoma. Glands with high-grade pin have 2 or more distinct cell layers. And one variant, which is called pin-like prostatic ductal adenocarcinoma, where the glands are crowded. They are basically ductal adenocarcinoma, but shows some common features like prostatic intraepithelial neoplasia. Sometimes in benign prostate, high-grade pin like nuclear changes, but their number are less than 10% in a gland. So what is the ISC findings of high-grade pin? In high-grade pin, Amaker is positive, P63 positive, high molecular weight keratin positive. So all 3 are positive. In cancer, Amaker positive, P63 negative, high molecular weight keratin negative. That means in cancer, the basal cell markers are negative. But in high-grade pin, the basal cell markers are positive. At the same time, epithelial markers are positive. And in normal, epithelial marker is negative, but the myoepithelial markers are positive. So high-grade pin share both the normal and cancer IC markers. And here is the predictive odds ratio. If number of cores with high-grade pin is 1, if you find only high-grade pin in only 1 core, then the odds ratio is almost 1. That means chances of prostatic adenocarcinoma is almost equal. If 2, then odds ratio is 1.5. If 4, odds ratio is 2.66. That means if 4 cores shows high-grade pin, then chance of prostatic adenocarcinoma is 2.5 times higher. Now here is a table showing the benign feature, entities. That means adenosis is the key feature where is gradual transition between normal and small glands to population of cells. This is the adenosis, sclerosing adenosis. Here also gradual transition between normal and small glands, but not to population of cells. Atrophy. Here, sharp angulation of glands. Here is the picture. Basal cell hyperplasia, two distinct cell population. Then bulbourethral gland. This is the bulbourethral gland. Seminal vesicle, how it looks in a core biopsy sample. Radiation effect, marked nuclear size variation and increased stroma. Then prostatitis, we saw this fasciitis nodosa. So these are the entities which might be seen in relation to benign conditions. Now, atypical small acinar proliferation, it is also known as suspicious for carcinoma. But atypical small acinar proliferation is preferred as it does not contain the word carcinoma. And it is a waste basket diagnosis. It is not considered as entity with a distinct pathobiology. And it is analogous to ASCAS on a pap test. So when we should call ASAP, and it should not, we should not make often diagnosis of ASAP. One benchmark is less than 3 to 5% of all prostatic biopsies, and never diagnosed on an excision biopsy. So in a prostatectomy specimen, you cannot make a diagnosis of atypical small acinar proliferation. Cancers diagnosed in biopsies after ASP are not more frequently clinically significant than cancer diagnosed after a diagnosis of benign or high-grade PIN. Its feature, its criteria is like prostatic adenocarcinoma, but limited extent. This limited extent is the key feature. So less than 6 glands. If you find features of prostatic adenocarcinoma, but in less than 6 glands, then you can call it ASAP. And most of the times, deeper cuts did not yield anything. This is also very important. So if you, in one slide, in one section, you see adenocarcinoma-like feature, but it involves less than 6 glands, and you do a recut, and then it is gone, it is ASAP. There is no agreed upon minimum number of glands. However, one paper suggests that agreement among experts is low with 5 or less glands. And its differential diagnosis is prostatic adenocarcinoma and some benign prostate like adenosis of prostate and sclerosing adenosis of prostate. This is the ASAP. And how to suspect ASAP? You see the normal glands, and within normal glands or in between normal glands, there are small glands, but their number is minimum. After scanning a section, you find only 4 or 5 glands which are abnormal, which are small, then you can call it ASAP. And its ISC findings are almost like adenocarcinoma. So usually it is stains like cancer, MKR positive, and the myoepithelial markers are negative. Now the main topic is prostate cancer, and prostate cancer is most commonly diagnosed male malignancy in Europe and in USA, but in our country it is not true. Not true means we don't find the commonest cancer in male as the prostate cancer. In our situation, the prostate cancer ranks far behind. According to SEER data, in 2017, (161) 360 new cases were found, that is 9.6% of all newly diagnosed cancer cases, and a large number of patients died with prostate cancer. The vast majority of prostate cancers are carcinomas and could be labeled as prostate carcinoma. Most prostate carcinomas are gland forming. Thus, they are called prostatic adenocarcinoma or adenocarcinoma of prostate. Its incidence is increased with age. Usually, these cancers are indolent, and most old men die with prostate cancer, but not from prostate cancer. So most men die with prostate cancer, not from prostate cancer. That means they die due to other reason, but they have prostate cancer. So the risk increased with BRCA or BRCA2 gene mutation, and families have a mix of breast cancer and prostate cancer. BRCA2 mutation risk 8 times increased risk for men over 65 years old if BRCA2 mutation is present. And PSA, we know it is a kallikrein related serine protease produced by secretory epithelium and drains into the ductal system, and it cleaves and liquefies seminal coagulum formed after ejaculation. Serum PSA is seen higher than 4 in 80% of the patients with histologically documented cancer, but also in 25 to 30% with nodular hyperplasia, prostatitis, infarcts, prostatic masses. Even after cystoscopy, PSA can be raised. Elevated in 2 of 18 post-race marathon runners. So after marathon race, PSA can be elevated. Serum PSA may be normal in prostatic duct carcinomas. And prostate carcinomas secrete 10 times the PSA of normal tissue. So prostate carcinoma cells secrete 10 times PSA in comparison to the normal non-carcinomatous prostate tissue. Annual testing was traditionally recommended for men over 50 years and 40 years at increased risk. Routine screening, it was previously it was recommended. Routine screening using PSA with or without digital rectal exam does not significantly affect mortality overall from prostate cancer. So American College of Preventive Medicine does not recommend routine population screening with digital rectal examination or PSA. But related clinical test is PSA density, that means PSA per volume of prostate gland, PSA velocity, then percentage of free PSA. These are more important tests than the total PSA alone. So in patients with PSA more than 10, but no known prostate carcinoma, there are certain soy, isoflavones, and curcumin, they reduce PSA level. Now the correct diagnosis and grading is crucial for a patient's prognosis and therapeutic option. The Gleason grading is the most commonly used histological grading system and continues to be the single most powerful predictor of prostate cancer prognosis and plays a significant role in clinical management. And Gleason grading is now recommended by WHO. This is the staging. Will come later on also, but just to have a look and just to refresh our knowledge. Now I would like to focus some very basic aspects of management, because it will help us to concentrate in which aspects we'll have to be careful while reading prostate cancer slides. So the management changes between Gleason score 6, 7, 3 plus 4, and 7, 4 plus 3, and 8. So management changes. So with Gleason score, changing Gleason score, management changes. Typically the implications are Gleason 6, it just observation, or radioactive seeds, even surgery if patient wants. So with Gleason score 6, no aggressive treatment is given. Then Gleason score 7, with a bit of Gleason pattern 4 and low tumor volume, it is reasonable to watch or do something. Gleason 7 with a lot of Gleason pattern 4 or a high tumor volume, do something, either surgery or radiation therapy. Gleason score 8, it is bad cancer, do something quickly. So bottom line is, you want to be sure when you call something Gleason pattern 4, because Gleason pattern 4 is bad, and do something quickly. So it is very important for the urologist and also for the pathologist also. That's why I bring this issue of management. And observational strategies, actually it is delay of definitive treatment, either surgery or radiation. So they just want to observe the patient. And it is common in management of prostate cancer, active surveillance and watchful waiting. These two are observational strategies. So active surveillance, that means they select those patients who have low risk of progression. This patient may get definite treatment later, but now they just keep the patient under surveillance. And watchful waiting, this is another strategy. And in this group, the patients who have higher risk of progression. So these two are observational strategies, and this strategy is recommended by all bodies. So which patients undergone active surveillance? Gleason score 6 or less. All biopsy course if less than 50% involvement. 1 or 2 course involved. And clinical criteria is if PSA is less than 10 and negative DRE. So these are criteria for active surveillance. So now we'll go to the diagnostic criteria as a list. So ABC of prostate pathology. Major criteria is the ABC of prostate pathology. What is ABC? A means architecture. B means basal cells lacking. And C, cytological abnormalities. So this is the diagnostic criteria and major criteria. There are some minor criteria also. So architecture, increased gland density. You see, full of glands. So increased gland density. And what is the criteria or what is the characteristic of these glands? The glands are small in size. They are small circular glands. And in rare subtypes, there are some large branching glands, but mostly they are small circular glands. Infiltrative growth pattern. So how will you know that it is infiltrative growth pattern? Malignant glands between benign ones. You see, these are benign glands. These are benign glands, normal glands. And in between the benign glands, these are these small glands. So in between, here is normal gland, normal gland, normal gland, normal glands, normal glands. So in between normal glands, these small glands, this is the infiltrative growth pattern. Then basal cell lacking, like breast, and sometimes it is very difficult to appreciate lacking of basal cells. And in those cases, we need help of ISC. Cytological abnormalities, nuclear enlargement, but that is very subtle. Nucleoli prominent. If you find prominent nucleoli, then it is cancer. And minor criteria, nuclear hyperchromasia, wispy blue mucin. You see the mucin and its color is bluish. Then pink amorphous secretion, intraluminal crystalloid. So these are intraluminal crystalloid. And I think you remember previously I have shown you the previously we saw another intraluminal bodies, and it is very different from that. Amphophilic cytoplasm. The cytoplasm is bluish to red. And in the adjacent area, you can find high-grade pin. Mitosis quite rare. Even in the high-grade lesions, you will not find mitosis. The next important is extent or quantity criteria. There is no agreed upon minimum number of glands. However, one paper suggests that agreement among experts is low with 5 or less glands. Thus, it has been suggested that 6 or more glands should be present to diagnose cancer. Features considered pathognomonic for prostate carcinoma by some authorities: perineural invasion. And perineural invasion must be circumferential. More than 95% of circumference should be involved by the glands. Glomeruloid bodies and collagenous micronodules, also known as mucinous fibroplasia. So these features are considered as pathognomonic features. Now there are some low power feature. There are some high power features. So low power feature, architecture. And architecture is the key to diagnose on low power and also low grade cancer. Back-to-back glands or crowding of glands. If you see, think low grade cancer, and it is Gleason pattern 3. Sharp transition between gland border and lumen. Loss of epithelial folding at the epithelium gland lumen interface. So there is sharp punched out appearance. Then eosinophilic debris within the gland lumen, which is called intraluminal crystalloid. Then blue tinged acellular material in the gland lumen, that is mucin, and infiltrative growth pattern. So these are features of low power. And in high power, you will have to see the nuclear changes. You can see hyperchromatic nucleus like high-grade pin, nuclear enlargement, large nucleoli. So all these features you will have to see by high power. Loss of basal cells, it is also seen in high power, and it is also a diagnostic feature. And as I told previously, that mitosis is not a common findings, and if you find them, the lesion is high grade. But it is not advisable that you try to look for them because it is very rare. Now, key reasons for false negative prostate samples. Tissue artifacts, then crash artifact, thick sections, aberrant H&E staining, freezing artifact, and cautery. So these are actually causes for false negative prostate sample. And another entity, minimal adenocarcinoma. When we should call minimal adenocarcinoma? Less than 1 millimeter long or involving less than 5% of a core biopsy. Then we can call it minimal adenocarcinoma. This slide, I think it will come to this slide later on. Another entity, vanishing cancer. This is an interesting nomenclature, an interesting entity, first described in 1995. Vanishing cancer indicates no residual tumor found in radical prostatectomy specimen despite confirmed tumor in needle biopsy. So in needle biopsy, there is confirmed cancer, but after radical prostatectomy, there is no cancer. Sometimes only high-grade pin or SNI suspicious for, but not diagnostic, that means ASAP is found, and it is staged as PT0. So most often the phenomenon is attributed to the fact that routine histologic sections cannot evaluate every cubic millimeter of prostate volume. So small cancer foci may remain in the wax. So this is one explanation, that the small cancer foci, which has not been examined, it is within the paraffin. And rarely prostate cancer may have been ablated by the biopsy or by transurethral resection procedure. The whole cancer has been ablated. It is also proposed that a minute cancer focus at the edge of the prostate may be inadvertently left behind in the overzealous attempt to perform a nerve sparing procedure. That means the cancer is present, but it was not removed because the urologist attempted to perform a nerve sparing procedure. So the cancer is there, and the non-cancer portion is examined, and we cannot find any cancer. So this is the vanishing cancer. Now there are some variants that mimic benign: atrophic prostate carcinoma, pseudo hyperplastic adenocarcinoma, foamy gland adenocarcinoma, pin-like adenocarcinoma, and microcystic adenocarcinoma. So these 5 pattern or these 5 variant, they mimic benign. Sometimes single cells of Gleason 5 adenocarcinoma can be missed, and these cells are mistaken for lymphocytes. So you think that all these cells are lymphocytes, but they are Gleason 5. So IC for cytokeratin for these cases are advocated, and treatment effect. So check initial information and look for treatment effect in benign glands. Now the most important, we know now we use modified Gleason grading system because it has been changed twice. The original Gleason grading system has been changed twice, so we call it modified Gleason grading system. So Gleason grading system is most important topic . I would like to remind you that prostate cancer is multifocal, and the question all arise from single cell or multiple tumors forming independently. So in prostate, you can have this is one tumor, this is one tumor, this is pin-like. They are like this. And so when a clinician does a core biopsy, his needle can go through this, his needle can go through this, his needle can go through this site. So if this tumor portion is not fired, then even with the presence now, there are some terms. One is Gleason pattern, grading, Gleason score, combined score, grade group. So these terms, sometimes we use Gleason pattern, sometimes someone use Gleason grading, Gleason score, combined score, grade group. Among these terms, Gleason pattern and grading both are same. Gleason pattern and Gleason grading same thing. Gleason score. Gleason score is for each pattern, one number is assigned. For Gleason pattern 1, the score is 1. For pattern 2, score is 2. For pattern 3 is 4. For pattern 5, score is 5. So combined score combination of primary pattern and secondary pattern. So that is called combined score. So in a cancer, the highest score can be 5. So 1, 2, 3, 4, and 5. And combined we write Gleason score, then it means 1 to 5. And if we write combined score, it means 2 to 10. And grade group, this is a new term, and we will come back at, later on. So Donald F. Gleason, he actually invented and he actually introduced the scoring system, and upon his name it is called Gleason score. He was born in 1920. He graduated in 1945. In 1950, he became chief of pathology in Minneapolis Veteran Administrative Hospital of USA, and he died in 2000. So when Gleason began his work in 1960s, pathologists used various systems for classifying the progression of prostate cancer and predicting its course, which made comparison difficult. And in that time, George Bellinger, and George
ডক্টর মুস্তফা মিউট হয়ে গেছে।
they took participate in that study. So patients were coming from different institutes, and they had different types of reports. They have different types of description. So it was very difficult to fit which patient in which group, which Mellinger asked Gleason to develop a system that could be used to communicate the results of a multi-group research project so that everybody can understand what he is trying to say. So Gleason was given that responsibility, and Gleason studying histological slides from 280 pages, and he found that the range of histopathology could be described in 9 different pictures of cellular architecture, and finally bring them 5. So Gleason saw 9 different types, 9 different patterns, and he then brings these 9 patterns into these 5 groups. So he draw 1, pattern 2, pattern 3, pattern 4, and pattern 5. So this was the initial contribution made by Gleason. So pattern 1 or grade 1 the glands form a compact mass. Then grade 2, some glands invade into the surrounding stroma. Then grade 3, distinct glands with surrounding stroma. Grade 4, irregular tribiform glands. Grade 5, solid sheet with comedonecrosis or single cells. So this was the drawing initially made by Gleason. In real life situation, small malignant glands infiltrating between benign prostatic glands. It is the pattern 3. This is the cribriform glands and fused glands. It is pattern 4. The same pattern 4, and the single cells pattern 5. Now, pattern 1 and pattern 2, these first on biopsy course, as circumscription cannot be assessed in core biopsies. So these two patterns should not be assigned on core biopsy. So original Gleason formulated in 60s, validated in 70s. Here only architecture was considered, not the cytology, and accounts for tumor heterogeneity, score based 1 to 5, and the sum score X plus score Y, that means score Z, that is the combined Gleason score. And the rule was X is the most common tumor growth pattern, that is primary score. Y is the second most common pattern, so second score. And if the second pattern is less than repeat, that means repeat most common pattern. So just double the common pattern. So if the predominant pattern is 4 and the second pattern is less than 5%, then 4 plus 4, that means 8. So this is the original Gleason. Now, when the scores are later compared to patient's outcome, there was a strong correlation between Gleason's histologic picture and the patient's death rate and cancer-specific death. In this picture, you can see this is the pattern 6. The prognosis is very good, and this is the pattern 9 or 10. You see the prognosis is very bad. So this pattern, which actually Gleason's contributed, later on seen that it has got tremendous correlation with the patient's outcome. The Gleason system was published in 1966 in Cancer Chemotherapy Report, but it was not widely used until several leading urologists recommended it. And they recommended it in 1987. So after 20 years of publication, people, other pathologists get started using Gleason system. And Gleason extended his work to a study of 4,000 patients and drew what is now widely used diagram of cell architecture of prostate cancer. And Gleason received a Lifetime Achievement Award from International Society of Urologic Pathology in 2002. The Gleason grading system was first included in the second edition of WHO. tumor classification in 2002. So Gleason's work was published in 1966, and in 2002, WHO recognized his contribution. So after a long time, WHO recognized Gleason. Now, at the later part of 20th century and early years of 21st century, certain interesting observations were seen. Some of the low-risk patients behave bad, and there were, in some cases, there was grade inflation and stage migration. Grade inflation means, you see, there are some people who always try to do something. They reviewed the archived cases, and they saw initially, which was diagnosed as Gleason pattern 6, now they reevaluate and they saw that it is not 6, it is 7 or it is 8. So when this happens, it is called grade inflation. So with this grade inflation, and also Dr. Epstein, he wrote an editorial in 2000 recommending that Gleason score 2 to 4 should not be assigned to cancer on prostate needle biopsy. Before 2000, the pattern 1 and pattern 2 were frequently reported by the pathologist. But in 2000, Epstein wrote this editorial, and he told that poor reproducibility, even among expert uropathologists, poor correlation with radical prostatectomy grade, with almost all cases showing higher grade and higher stage at resection. A diagnosis of Gleason score 2 to 4 may misguide clinicians and patients into believing that patient has an indolent cancer or indolent tumor. So with this editorial, a lot of things has been changed. In 2005, Gleason grading underwent first major revision. International Society of Urologic Pathologists organized an international consensus conference in 2005, and they identify the problems of original Gleason score. Some pattern 1, actually likely adenosis. Pattern 2, rare and cannot be diagnosed on small needle biopsy sample. Not all possible growth patterns represented in the original Gleason. Inter-observer variability, graded prognostics. Some descriptions were vague, as cribriform 3, pattern 3, there are some cribriform pattern. In pattern 4, there are some cribriform. So the description was vague. And it again made inter-observer variability. And no rules for when more than 2 patterns are present. So they identified these are problems of original Gleason. So first modification of the Gleason grading system was in 2005. And in that meeting, officially they accept poorly formed glands as pattern 4. So if there is poorly patterned glands, it is pattern 4. And modify the rules for grading needle biopsies to report the most prevalent grade and the highest grade as opposed to the two most common grades. So initial rule was primary pattern and the secondary pattern. Now they changed into the primary pattern, that is the most prevalent grade and the highest grade, not the second prevalent grade, the highest grade. then report different grades for each separate tumor nodule in a radical prostatectomy sample. So if a radical prostatectomy sample has got 5 different grades, so report separately. So that was the recommendation of this 2005 conference. Then report tertiary patterns in radical prostatectomy samples. To agree that Gleason pattern 1 and samples excluded cribriform glands in Gleason pattern 2 and tightened the criteria for cribriform pattern 3 so that only rare cribriform glands would be graded as pattern 3 and all cribriform pattern are shifted into pattern 4, and recommended reporting different Gleason scores for different positive cores as long as the cores were designated according to the location within the prostate. So if the urologist, they labeled this is from left upper, this is from left middle, this is from left basal, this is from right basal, this is from right middle or right apex, report differently, assign differently. So what is the conclusion of this 2005 consensus conference? So this is pattern 1. They just dropped the pattern 1. And as the pattern 2 is very rare, so this pattern is also discouraged. So here you see the cribriform pattern in pattern 3, in pattern 4, and also in pattern. What they did, they revised the picture, they revised the drawing, and they just shifted this cribriform part from pattern 3 into pattern 4 and also from pattern 5 into pattern 4. So they squeezed this portion, the cribriform portion, all cribriform into pattern 4. So this is the new drawing, the pattern 1, 2, 3. So they excluded all the cribriform portion into pattern 4. Now, you see, this is an example. The vast majority is, the commonest pattern is pattern 3. Then the second common pattern is pattern 4. And pattern 5 is the least pattern. So what happens here? The original Gleason is 3 plus 4, 7. So originally it was 3 plus 4. But in 2005 modification, it becomes 3 plus 5, 3 plus 5, because it is the most prevalent one and this is one is the highest. So most prevalent plus highest grade. So this is 5, 3 plus 5, 8. So initially it was 3 plus 4, now it becomes 3 plus 5, 8. So initially, this is another example. The most prevalent one is 4. And then second one is the 3. So original Gleason is 4 plus 3. But now it's called, if it is less than 5%, then just double it. So in 2005 modification, it becomes 4 plus 4, 8. The same thing, but there are certain issues unresolved in 2005. Some issues are still not resolved in 2005. For example, small cribriform glands were still retained as pattern 3. no agreement reached on grading mucinous adenocarcinoma of the prostate or glomerular pattern. So this is another issue unresolved in 2005 consensus conference. No recommendations regarding the reporting of grading of intraductal carcinoma. So these were unresolved in 2005 consensus conference. And in the clinics, there were some problems. And what is the problems? You see, with this 2005 modification, the best lowest score became 3+3, that means 6. So you cannot report 3+2 because it was not advised. You cannot make a report of 3+2 or 2+3 or 2+2 on core biopsy. So minimally, if you think it is a cancer, you will have to report it as 3+3. This is the best or lowest score on a 2 to 10 scale. And this is the candidate for conservative management. That means just watching that patient or active surveillance. Now, how the patient react? So if you have a patient whose Gleason score is 6, and you decide and you ask him that, okay, you have nothing to be worried and nothing to be done. You just go as usual, and after a few days or after a few months or after 6 months, you come to me and we'll see again. Now, what is the reaction by the patient? Patient thinks the score is 2 to 10 and my score is 6. So it has crossed almost half. So my cancer is in the midway, and you are still saying that conservative approach. So it is very difficult to make the patient understand. Another issue, 3+4 is equal to 7. 4+3 is 7, but very difficult outcome. So both are 7, but very difficult outcome. So from the patient perspective, me and my friend, both 7, but you are telling me for operation, but for my friend, no operation. So why? So it is very difficult to convince the patients from the clinician's point of view, and also very confusing from the patient's perspective. So even with one modification of the original Gleason, the problems were not solved. So the second modification of Gleason system came in 2014. So in November 2014, another
সময় নাসিম সময় শেষ হয়ে গিয়েছে নাকি? 90 মিনিটস ছিল তোমাদের ইসে।
না স্যার, সময়ের জন্য না, টাইম এক্সটেনশন করা হয়েছে স্যার। ওই স্যারের কানেকশন চলে গেছে।
ও আচ্ছা আচ্ছা, ঠিক আছে। ওখানে ইদানিং তো তোমার ইলেকট্রিসিটি সামটাইমস রেগুলার হয়ে যায়। ও সৌমিত্র, তুমি করছো না, অ্যাডমিন হিসেবে কাজ করছো না?
জি স্যার।
Okay. So these are the outcome of this 2014 consensus conference. So the issue of mucinous carcinoma was addressed. Glomeruloid pattern and small cribriform glands issue were addressed. Then intraductal carcinoma was addressed, and new group grading system. So these are the outcome of this 2014 meeting. So it was agreed that mucinous carcinoma should be graded based on their underlying architectural pattern, as many studies have demonstrated a relatively favorable outcome in mucinous prostate carcinoma. So not that all mucinous carcinoma should be graded 4. Then glomerular and small round cribriform pattern that was still designated as Gleason pattern 3 in 2005, they were included in pattern 4. So glomerular pattern is considered as an early form of cribriform pattern. Intraductal carcinoma was not advised to grade if only intraductal carcinoma is present, but it is understandable that intraductal carcinoma always present with associated high-grade ductal adenocarcinoma. So if there is intraductal carcinoma, there must be a suspicion that there is duct carcinoma somewhere, and it should be graded as, the duct carcinoma should be graded as grade 4. So the issue of tertiary grade patterns were also addressed here. And another important issue is reporting percentage of pattern 4 in Gleason score 7. So if there is 3 plus 4, 7, the 4 portion, the grade 4 should be quantified. So maybe grade 3 is 55% and grade 4 is 40%. So the percentage of grade 4 should be quantified differently. This is the recommendation. And this one is a very important study, and it shows that do adenocarcinoma of the prostate with Gleason score 6 or less have the potential to metastasize to lymph node? In 2012, this study was published, and they have examined 14,123 cases. And out of these large number of cases, there was not a single case of Gleason score 6 or less with lymph node metastasis. So what is the conclusion? Gleason score 6 never metastasize. So this is the test for the pathologist. So if you give a report of Gleason score 6, and if later on that patient come with metastasis, then what it indicates? It was underscored. So considering all these things, they have proposed reporting of a Gleason score prognostic grade groups. So Gleason score 6, that means prognostic grade group 1. 3 plus 4, 7 is the prognostic grade group 2. 4 plus 3, prognostic grade group 3. Gleason score 8, prognostic grade group 4. And Gleason score 9 to 10, it is grade group 5. Now what happens? So you see, when it is 6, the patient thinks that I am in the middle, but now grade group 1. So you can easily make your patient convinced that your cancer is at the earliest stage because it is group 1. Then it is group 2, group 3, group 4, group 5. So the problem of clinical management is now much better. Now the problem is solved. So this was proposed in that conference, and WHO actually accepted it. And in 2016, WHO classification of prostate cancer, they have included in WHO classification. And there are several studies of this prognostic grade group with, so this study shows the grade 1 has got the highest prognosis and grade 5 has the lowest prognosis. So they have tested it in different ways, different type. So this is the new criteria of grade group. This is the grade group 1, 2, 3. So they have described the new grading system very well. So 1, that means individual, discrete, well-formed glands. Grade 2, grade 3, grade 4, and grade 5. So they have given in details of the criteria. So in 2016 edition, tumor of urinary system and main genital organs, this new grading system was included, but still there are some limitations in this grade group. Still there are some limitations, especially in grade group 4, Gleason score 4+4, 3+5, 5+3. So all are included in the grade group 4. And now there are some studies, they are showing that these B group, their subgroups, they behave differently. And another issue is grade group 1. Some pathologists are trying to say that it is not a cancer. So grade group 1 or 3+3, 6 is not cancer, because in the previously shown studies, it is told that these patients, they never metastasize. So why they should be called as cancer? So there are a group of pathologists, they want to say it as indolent lesion of epithelial origin, not prostatic adenocarcinoma. So they are trying to say that the grade group 1 is indolent lesion of epithelial origin. So there must be a decision of this. There are many urologists, they are also trying to say that grade group 1 is not a cancer. So in 2019, there was another consensus. So now we have 2005 consensus, 2014 consensus, and 2019 consensus. So this is a table, it shows that. And with all these things, there was a paper published in 2019. And here it is told that only 14.6% of the published article were grouped accurately. They made accurate diagnosis only 14.6% of the article. So still a lot of reports, a lot of patients are not grouped correctly. So the take-home message is Gleason score is subjective, imperfect, but strongest histologic prognostic factor. And pathologists remain in the driver's seat. The future is starting now. Use new grading system. And grade group 1 is probably not cancer. So these are the take-home messages of today's presentation. And the last slide of this is how I remember or how I actually grouped the patients, how I group the biopsy specimens. So if I see stroma in between glands, it is 3. If I see there are glands, but there is no stroma in between, it is 4. And if I see sheets, it is 5. So I use this. So I forget all the criterias. I forget everything. I remember only these 3 slides. So one is, if there are glands and stroma in between, it is 3. If there is glands but there is no stroma, it is 4. And if there is no gland at all, it is 5. Thank you very much.
Thank you, Professor Ghulam Mustafa, for his nice and elaborate deliberation. Now the time for our panelists to comment. First, I request Professor Syed Mukarram Ali. Sir, please say something. Sir, Mukarram Ali, sir. Sir, কি আমাদের ইয়েতে আছেন? স্যার মনে হয় এখন আমাদের সঙ্গে নেই। নেক্সট প্রফেসর মোহাম্মদ কামাল। স্যার আপনি কিছু বলবেন স্যার?
হ্যাঁ, অল্প একটু বলি। Thank you very much, Dr. Mustafa. It's an excellent presentation, very nice presentation, even more than what the residents need. Actually, this is what the practical things we should know. Every pathologist should know. So it's an excellent presentation. It's an international standard, more than international standard presentation. So I congratulate you again. It's very nice. And I hope that other presenters will also follow him and give seminars on the different topics. And to my junior colleagues and residents, I already requested Dr. Mustafa to give a handout which you can print, you can read, but before that, you go through your textbook and then read. And I think this contains enough information which you can use in your practical life, and also it will help you in passing the examination. Thank you very much, Dr. Mustafa, and thank you all for your attention. One question. Can I ask a question? Dr. Mustafa, does lower grade tumor eventually progress to higher grade? And what is the significance, or what is the incidence like this?
Actually, the lower grade tumor can progress to higher grade, but it takes a lot of time. And that is why the recommendation is watchful waiting. Actually, even the lower grade tumor, when you will have to select that this patient will go for active surveillance, this patient will go for watchful waiting. Now, there are certain characteristics. Not only grading, the percentage of core involved is also important. The perineal infection, all the informations are very important. That's why I told that the pathologists are in the driver's seat. because without our detailed report, an urologist will never be able to manage the patient, because they need every information. And nowadays, the criteria for grouping the patient for active surveillance, grouping the patient for watchful waiting, or uh, taking the patient into OT or into radiation or chemotherapy, it is very strict. So in every aspect, even a lower grade tumor need immediate attention. If the other factors are very much vulnerable.
Yes, thank you. The other point is occult cancer that is commonly used during our student time and also now it is in clinical. So I think especially the younger ones should know that occult cancer is cancer. You are getting persistently elevated PSR. So in that case, extensive workup is needed, extensive. So as Dr. Mustafa has said, that multiple course and then prostate mapping is needed. Thank you. Dr. Nasim, you are muted.
স্যার আমি স্যার কোশ্চেনগুলো একটু পড়ে শোনাচ্ছি স্যার।
বলেন।
শাহাবুদ্দিন জানিয়েছেন, থ্যাঙ্কস জানিয়েছেন। আর এরপরে গুলশান বানু কোশ্চেনটা হলো, if we find patterns less than pattern 3, what will be the diagnosis if not prostatic cancer? মনে হয়
Dr. Mustafa can answer this.
Mustafa can
What
answer
is the question? What is the question?
If we find patterns less than pattern 3, what will be the diagnosis if not prostatic cancer?
If not, oh,
prostatic cancer.
You see, if it is less than pattern 3, you cannot make a diagnosis of less than pattern 3 on core biopsy. And the gold standard of diagnosis of prostate cancer is on core biopsy. So if it is core biopsy, you cannot make a diagnosis of pattern 2 or pattern 1. It is not possible.
It has to be 7 or above.
Has to be 6.
6 or
the
above.
Lowest is the 6.
6 and above. Yes.
6 and above. And I tell you one thing, I get many patients for review, many slides for review, and it was reported as pattern 4. Combined score is 4, 3 plus 1, 3 plus 2, and all I give report at least 7, even 8. Even recently I reported one case as 9, but it was reported as 5.
All these are
under reporting. Yes.
And all these are in core biopsy or some are in
yes core biopsy.
Oh, that is, they should actually, if they are listening, then this is an important message for all of us.
So from Mahbuba Jhumur to thank you, sir, for your wonderful and very much informative presentation. From Dr. Nafil Islam, Professor Nafil Islam, thanks to Professor Ghulam Mustafa and BAP. From Dr. Masood Parvez, thanks.
Question গুলো পড়ে
question let me see sir একটু দেখি না আর কোনো ফার্দার কোশ্চেন নেই এখানে থ্যাঙ্কস জানিয়েছেন অনেকেই আর আমাদের প্যানেলিস্টের মধ্যে ডক্টর জয়নাল ইসলাম কিছু বলবেন কি or Dr. Saika Habib?
Sir, thank you very much, sir. In fact, Professor Mustafa sir has covered everything. Almost, it's a very elaborated and excellent presentation. I must congratulate Dr. Mustafa sir. Just I want to give some small emphasis. And sometimes we get some other lesion in the prostate, like urothelial carcinoma invading the prostate. It mimics like prostatic carcinoma. Sometimes this become it may make some confusion. So in those cases, sometimes we have to depend on the clinical scenario, as well as we have to go for some ISC staining, immunohistochemistry staining, to differentiate urothelial carcinoma from prostatic carcinoma. And in certain cases, even we get rectal carcinoma. They have invaded, they have invaded the prostate, and it mimics like some mucinous changes, or even without mucinous changes. Sometimes it mimics like prostatic carcinoma. So we should think, we should keep in our mind this type of lessons, I think. And recently, this in NCCN guideline, I think gradually they have incorporated the recommendation for some genetic testing. So we must think for introduction of those things in our cases also. So this is about the today's. Yeah. Thank you very much, sir, for giving me the floor.
Thank you, Brigadier Joinul Islam. Now, Dr. Saika Habib, will you have any comment, please?
Assalamu alaikum. First of all, I want to thank our respected Professor Ghulam Mustafa sir for his informative and elaborative presentation regarding prostate pathology. And as Dr. Joinul also mentioned, is that genetic testing, yes, there are some. I just want to mention the names as well, because like the linkage analysis, it is already established, and there are some other genetic tests like genome-wide association studies and copy number variation, also the whole genome sequencing study. So if we perform a combination of both the genomic and as well as the molecular biomarkers, then we can improve the diagnosis, prognosis, and management strategies of each prostate cancer patient. Thank you.
Thank you, Doctor. Thank you, Dr. Saika. Now, the closing remarks to be made by our General Secretary, Dr. Nurul Kabir. I request Dr.
Dr. Nasim, can I tell something?
Yes, sure. Sure.
Well, at first I like to thank the
Dr.
Association of the
please,
Pathologists for inviting me. Actually, this is for Dr. Sudhir Das Gupta. He is in Puja occasion, that's why I'm here. So I'm very much pleased to see my teachers, especially Professor Kamal sir and Professor Ghulam Mustafa sir. Yes, Ghulam Mustafa sir has covered nicely, and I think that was the wonderful lecture I have ever heard. And if you included the resident of the urology, they would have been also benefited from your lecture also. So regarding the genetic counseling, that is required, and NCC guidelines recommended to do it in case of grade group 2, 3, and 4. That is the Gleason score 7, either 3+4 or 3+3. And if there is any linkage is found, in that cases, in subsequent screening program, in case of the person like their son or others successors, that should be started before the age of 50, because they got a high chance of getting development of the prostate cancer. So that clinically, that is also very much important. And Gleason scoring is nowadays so much important, because if we can't get a proper Gleason scoring, we can't actually put the patients into our risk stratification group. So total clinical management nowadays depends on the Gleason scoring. So thank you very much for this nice presentation once again.
Thank you, Dr. Fazul Nasir. Thank you very much for your giving us time. And now,
Nasir, what about the slide quiz?
Slide quiz ta ki korte chacche?
না, যেটা হয়ে গেছে সেটার এক্সপ্লেনেশন কি ডক্টর মুস্তফা দেবেন?
আমি কি এখন আচ্ছা
ব্রিফলি
ওটা অ্যান্সার গুলো স্যার হলে ভালো হয় না?
আমি আসলে এই প্রেজেন্টেশনটার এই লেকচারটার দুটা পার্ট মানে আরো একটা পার্ট হবে, মানে যদি আরো একটা পার্ট হবে মানে যদি সবাই সেটা চাই আর কি। ইনফ্যাক্ট হলো আসলে এই প্রেজেন্টেশনটা আমি গত কয়েক বছর থেকে করার চেষ্টা করছিলাম, তো কিন্তু বেশিরভাগ আমি যতবার প্রস্তাব দিয়েছি ততবারই সবাই আরো অন্য কিছু শুনতে ইন্টারেস্টেড হয়, যার ফলে এটা করা যায় না। তো এটা 2016-তে যখন প্রথম WHO ব্লু বুক বের হয় অন প্রস্টেট অন মেল জেনিটাল সিস্টেম, ঠিক সেই সময় আমি জার্মানিতে একটা কনফারেন্সে ছিলাম। ওই কনফারেন্সেই তখন হট কেকের মতো আসলে এই ইস্যুটা আসলো, ওই বই বিক্রি শুরু হলো এবং ওই কনফারেন্সের বেশিরভাগ প্রেজেন্টেশনই হচ্ছে এইরকম। ওটা হলো ইন্টারন্যাশনাল একাডেমি অফ প্যাথোলজির ওখানে আমার একটা প্রেজেন্টেশন ছিল। তো সেই সময় সেই ইয়েতে যেই আমি প্রথম এর সাথে ইন্ট্রোডিউসড হলাম। তো তারপর থেকে সেই 2016 থেকে 20 এই 4 বছর আমি কিন্তু বিভিন্ন সময় চেষ্টা করছি যে এটা করার জন্য। আমি বাই দিস টাইম ইউরোলজিস্টদের, ডক্টর ফজল যে বলছিলেন যে ইউরোলজি রেসিডেন্ট, তো ইউরোলজিস্টদের অনেক কনফারেন্সে কিন্তু আমি এই লেকচার ছোট ছোট করে আমি দিয়েছি। তো কিন্তু শুধু আমাদের প্যাথোলজিস্টদেরই এটা ইয়ে করতে পারছিলাম না। তো যাই হোক, ওই জন্যই এই বছর প্রথম দিকে যখন এটা নিয়ে কথা হয় তখন ইয়ে করছিলাম। তো আজকে আসলে এটার দুইটা পার্ট। এটা প্রথম, আমরা তো আসলাম কেবল গ্লিসন স্কোর শুধুমাত্র আজকে। তো নেক্সট আরেকটা হবে, সেখানেই হলো আমরা ওই অ্যাডভান্স যে পোর্শনটা, যে এটা আমার ইয়ে ছিল যে বেসিক টু অ্যাডভান্স, সো অ্যাডভান্স পোর্শনটা সেখানে যাবে এবং বিভিন্ন যে সাবটাইপ, সেই সাবটাইপ কি করে ডায়াগনোসিস করতে হবে সেটা আমরা সেখানে দেব এবং এই কুইজ নিয়ে আলোচনাও সেখানে হবে আর কি। তো একটা যেটা বলি যে কুইজে যে যতটুকু আমি দেখছি সেইটা রেজাল্ট খুব একটা ভালো না।
না, সেটাই এক্সপ্লেইন করবেন, সেটাই এক্সপ্লেইন করতে হবে।
সেই এক্সপ্লেনেশনটা হবে ওই সাবটাইপের সাথে সাথে এই এগুলো কুইজ গুলো ইয়ে করা হবে আর কি। তো আমাদের নেক্সট আরেকটা প্রেজেন্টেশন হবে, সেখানে
রিকোয়েস্ট করব যে সাবটাইপ যখন করবেন তখন অনেকগুলো ফটো মাইক্রোগ্রাফ দেবেন, এগুলো দ্যাট উইল মানে হেল্প মোর। এই মানে এটা আমার রিকোয়েস্ট যে এটা হয়তো এইভাবে তখন সাবটাইপ গুলোর মধ্যে ডিফারেন্সিয়েট করার জন্য ওই ফটোগ্রাফস গুলো বেশি হেল্প করবে। আর কি প্রফেসর আসিম বলবেন নাকি?
আসিম স্যার তো বলেছেন। প্রফেসর নুরুল কবির কিছু বলবেন?
জি জি। Honorable President, respected members of the expert panel, teachers, colleagues, and all the participants, I am Dr. A.K.M. Nurul Kabir, General Secretary, thanking you everybody on behalf of BAP. It is a bit late due to Corona pandemic and was not possible to arrange the physical session. So we have taken the help of virtual activity. Professor Muhammad Ghulam Mustafa, our proud, agreed to deliver the lecture, thanking him for his interest. We also giving thanks to the member of the panel of experts, giving their time and valuable opinions. And a special thanks for Dr. Soumitra for his technical support. We are grateful to the participants for attending the session. I think that it will be much helpful in their practicing life. And thanking you everybody again.
Thank you.
Thank you. আমাদের কনক্লুড করার সময় হয়েছে।
নেক্সট ইয়ে কবে হবে কি করে ফেললেন?
আমরা তো স্যার এখন এটা করতে পারি স্যার, এটা করতে পারি, আমাদের এক কাপ চা খাওয়াতে হয় না। এর
না,
একটা
না।
সুবিধার দিক আছে স্যার
না
এখানে।
না ঠিক আছে, চা পরে খেয়ে নেবো আমরা।
ভার্চুয়াল চা।
হ্যাঁ,
হ্যাঁ,
কিন্তু
virtual।
আপনি ইয়ে করে ফেলুন ডক্টর মুস্তাফার নেক্সট প্রেজেন্টেশনটা কবে হবে, আর মাঝখানে অন্য কিছু হলে সবাইকে ইনভাইট
আমরা
করেন।
এটা
হ্যাঁ,
আচ্ছা।
থ্যাংক ইউ।
মুস্তফা যখন মানে বোঝা যাচ্ছে আরেকটা পার্ট আমাদের রয়ে গেছে, আমরা আশা করবো যে আসলে ওই দিন শর্ট টাইম আমরা আলাপ করে রেডি করে একটা
হ্যাঁ, এটা আপনাদের উপর,
কমপ্লিট করতে হবে। জি স্যার।
এটা আপনাদের
ঠিক
উপর।
আছে স্যার, আমরা চেষ্টা
থ্যাংক
করব।
ইউ ভেরি মাচ।
থ্যাংক ইউ ভেরি মাচ স্যার
থ্যাংক
ফর
ইউ
দ্য
ভেরি
পেশেন্ট
মাচ।
হিয়ারিং।
গুড নাইট, খুদা হাফেজ।
জি, আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম।